Okay, this is part 3 of sexual dysfunction. Dysfunctional uterine bleeding. DUB is what this is often abbreviated as. So what is this? This is vaginal bleeding in an abnormal amount, duration, or time of occurrence. So this could be a large amount of bleeding, or maybe the menstrual cycle has been going on for, 2 weeks, 3 weeks, a month, 2 months, something like that. Those are all common forms of dysfunctional uterine bleeding. So for diagnosis, there's going to be several tests that need to be done, looking at CBC, thyroid function tests, serum, estrogen, progesterone levels, HCG, LH, the luteinizing hormone levels, a pap smear, pelvic ultrasound, laparoscopy, and endometrial biopsy. So they're looking at all these different types of influences. Typically, it is caused by a hormonal imbalance, that there's not enough progesterone in relation to the amount of estrogen that is in the system. So looking for that cause. So if there is no obstructive cancer or any defining structural cause, often medication is going to be preferred over surgery. Now, if they find, a very large fibroid or uterine cancer or something like that, they're going to go in and probably do a hysterectomy. So what medications are we going to see used here? So oral contraceptives or a progesterone preparation is going to be used to try to stop that bleeding, okay, to get the cycle to just end. And then iron supplementation, just because usually these are with a lot of vaginal bleeding, that we got to start treating this iron deficiency anemia that's happening in the on the side with this. And so that's why that is on board to treat. Don't forget those things that you have to remember with giving iron, with vitamin C, not with dairy products. And then it causes constipation and dark stool. For surgical treatments, we're looking at the D&C, where they dilate the cervix and then go in. That's what's pictured above there, and scrape the uterine tissue. An endometrial ablation, where they essentially kill the endometrial tissue, and that usually will stop periods altogether. It is one of the treatments for that. A hysterectomy, we can have total hysterectomy where they take ovaries, fallopian tubes, and the uterus. Or you can have an oophorectomy, which is going to be just the ovaries, or a sublingual oophorectomy, which is the fallopian tubes and the ovaries. There's a nursing care checklist that is in your textbook. Take a look at that and just make sure that you have an understanding of those types of things. Other things that can be used would be those non-steroidal anti-inflammatory drugs. So with those medications, we talked about that. It's an antiprostaglandin. Bleeding has been known to be reduced as much as 50% with also having that on board. Some different terminology that you're going to need to know. Anovulation, a or and in front of a word, means absence of. So we have absence of ovulation. It is usually caused by a hormonal imbalance of some sort. Amenorrhea is going to be absence of menses, usually also caused by a hormonal imbalance. There's other illnesses and things going on that could cause amenorrhea as well. Anorexia, excessive athletic activity or training can cause this, just because there is a certain amount of body fat necessary for menstruation to occur. Then it's also normal for times to not have a period, such as during pregnancy, during breastfeeding, or even menopause. Those are all times that it is normal to have amenorrhea. Oligomenorrhea means scant menses, also caused by a hormonal imbalance. Menorrhagia, this is excessive or prolonged bleeding, can result from endocrine or reproductive system disorders. Clotting disorders or anticoagulant meds can have complications or consequences to this: excessive blood loss, fatigue, anemia, hemorrhage, and sexual dysfunction. Menorrhagia is bleeding between periods. This can be a sign of cervical or uterine cancer and needs to be evaluated promptly. All right, endometriosis. All right, endometriosis, this is when tissue that is normally found inside the endometrial lining of the uterus migrates to a different part of the body where it grows. This affects 7% of women. So what does endometrial tissue do? Well, it grows during a certain hormonal time in order to get nice and rich with nutrients for that possibility of a fertilized egg implanting itself in it. And then if that does not happen, then that endometrial lining has to slough off. So then that's when the period starts, when those tissues are sloughing off. So endometriosis now is where this is happening in a different area of the body rather than inside the uterus. It is unsure of how this exactly comes to happen, but we do know, there is an opening at the end of the fallopian tubes. Maybe some of those cells are escaping through there. That is one theory. So the cells can land in any of these areas on this picture here. You can look where these cells have landed in the bladder or on a colon or on the fallopian tubes, abdominal wall. These cells have come somewhere else. And so with those hormonal changes, you have this proliferation of tissue and then this sloughing of tissue, just like what's happening inside the uterus, except this is other tissues. Excuse me, and it can be very painful for these people. So risk factors, usually going to be a family history, but not necessarily. Early period, periods that are short, but having a heavy flow to them. This indicates high estrogen levels, and then having lower weight and smoking. Oral contraceptives in pregnancy may reduce the risk of developing endometriosis, and just like I had talked about, endometrial tissue outside of the uterus still responds to that ovarian cycle, still going to respond to those hormone levels. This causes infertility in approximately 25% of patients, because if that endometrial cells, if it lands in like the fallopian tubes, it causes permanent scarring in those issues, and it's hard for a fertilized egg then to travel down and get into the uterine tissue. Manifestations can vary. It just depends on what tissue they are affecting. Most often there's going to be a lot of dysmenorrhea. They're going to have a lot of abdominal cramping with this. Backache, cramps, painful defecation, dysuria, dyspareunia, and infertility. And, if the cells have landed on the bladder, then you're probably not going to have the bowel issues. You're going to have more of the urinary issues, that dysuria. Now, if the cells have landed on the colon, you're going to have more colon issues than you would bladder issues. So treatment, analgesics, getting some pain meds on board, especially that over-the-counter NSAID ibuprofen, that antiprostaglandin. Hormone replacement therapy has also been known to help. And danazol, DANAZOL, is an anti-estrogen steroid that has also been proven effective. Surgical treatments, this laparoscopic is usually used to get a visualization, try to explore and see where these cells are. It's sometimes very hard to pinpoint them. You go by the symptoms, and then they'll do kind of an exploratory surgery and see what they can find and where those cells are at. And if if it is a small condensed area, they can usually remove that laparoscopically. If not, sometimes an oophorectomy or some kind of hysterectomy is proven effective as well, putting that person through that surgical menopause. Okay, next we have toxic shock syndrome. This is a rare and acute illness caused by a Staphylococcus aureus infection. Things that put a person at risk: tampons left in too long, vaginal barrier contraceptives that are forgotten about, childbirth, abdominal surgery, septic abortions such as miscarriages, burns, and skin lesions. The pathophys, so this is where that infectious agent enters the bloodstream during any of those into, from an open wound. And the toxins are produced by the bacteria, causing vasodilation, which is going to lower blood pressure, and then hemodynamic instability, and then eventually into shock. Manifestations: high temp, abdominal pain, muscle pain, low blood pressure, and diffuse red rash. Typically, this is going to have manifestations all over the body. You're going to have altered mental status, some heart failure, arrhythmias, possibly pulmonary edema, some increased bilirubin, anemia, and then hypocalcemia. So treatments for this: identify the source of infection, cure the infection, getting those antibiotics on board, restoring hemostasis, meaning, looking at IV fluids to restore that blood pressure. Usually these people, if that sick, they're going to be in the ICU where they're continuously monitored and looking at that output every hour and respiratory status. So for output, we want greater than 30 cc's of urine every hour. Cervical cancer. Okay, definition. Talked about this. This is those cell changes that are happening in the cells of the cervix. Clinical manifestation, there's going to be not a whole lot of signs or symptoms of this. Once the cancer becomes pretty invasive where it's going into other tissues, then you may see bleeding or an increase in vaginal secretions. Risk factors are going to be, sexual promiscuity, having HPV. HPV causes nearly 70% of cervical cancers that are there. And prevention, we look at Gardasil and barrier birth control methods for preventing cervical cancer, and which just, it helps prevent that HPV. For diagnosis, we're going to look at a pap smear. They're going to go in and take a sample of those cells and send them into pathology and see what they can see. There's also a procedure called a colposcopy. That's what's pictured there, not video, pictured, where they actually take a biopsy of cells. They'll look for, cells that look different, like you can see in that lower picture there. There's also different tests they'll do. If your pap smear comes back with HPV, then they're probably going to do a colposcopy or kind of maybe wait and see what that pap looks like in a few months. It just depends on what that result shows. For treatment, usually going to be, some sort of radiation, maybe chemotherapy, and then also total hysterectomy may be recommended just because we don't know where else these cells have gone to. So here's cervical cancer screening guidelines. So less than 21 years, no screening is recommended. 21 to 29 every 3 years, unless they have some kind of abnormal testing or looking at their risk factors and they're pretty high. 30 to 65 every 5 years, greater than 65, not even worth doing the screenings. Ovarian cancer. So last thing we're going to go over. So again, this is cancer inside the ovaries. This is where those cells are growing outrageously fast. Risk factors, looking at greater than 50 years of age, early menses, late menopause, infertility, treatment of infertility with Clomid, family history of breast or ovarian cancer, because these things are driven by estrogen. Clinical manifestations are typically no early signs. Later symptoms are going to be mild pelvic pain, maybe urinary frequency, bloating, constipation. These are going to be very vague. Late sign is going to be ascites when we're looking at, kind of some liver involvement. This is also kind of known as the silent killer. It just, there's no sign or symptoms of it. Screening is extremely hard to do for ovarian cancer. And often when they find it, it's too late. So that's why they call this the silent killer. For other tests that can be done, CA-125 is a cancer marker, so we can do a blood test on that. It is not specific to ovarian cancer. It'll just signal like maybe there's a cancer happening inside the body. Transvaginal ultrasound can look for masses, but it is normal for ovaries to go through some mass changes because you have to think about the eggs that they're essentially getting ready, the cyst formation and that kind of thing that is already happening normally inside of ovaries. So it can be hard to detect those masses. And then laparoscopic they'll do for tissue biopsies. Treatment, it is usually going to be a total hysterectomy. They're going to take everything because they don't know where those cells have gone to. And the risk is just too great. Chemotherapy, the one I have down is paclitaxel. It is PACLITAXEL. That is the main chemotherapy for ovarian cancer. Oh, I guess I have it written up there on the slide as well. Okay, to finish up, we've got some Gordon's functional health patterns, some nursing diagnoses that are associated with this. So take a Look at this slide and fill in with your own notes.